Good evening and welcome to the Cancer Education Series. My name is Chris Goodale and I'm the Executive Director of Above and Beyond Cancer. These Cancer Education Series sessions are brought to you through a cooperative effort between MercyOne and Above and Beyond Cancer. And they are brought to you through a sponsorship that we have through a grant that we've received from the Iowa Cancer Consortium. It's my pleasure each week to introduce our founder, Dr. Richard Deming, who will introduce our speaker for this evening. Dr. Deming?
Thanks, Chris. And it is my pleasure to introduce to you all one of my colleagues that I get to work with every day, Lauren Winter. Lauren grew up in Illinois. She got her undergrad degree in biology at Iowa State, and then she also got her master's at Iowa State. She went on to get her master's in public health and genetic counseling degree at the University of Pittsburgh. And Lauren joined our team here at Mercy last year. She is a licensed genetic counselor. I think all of you probably realize the importance of genetics. We're learning more and more about it. It plays a very important role in assessing the risk that individuals may have for developing the cancer they're experiencing or for future cancers. And Lauren has just become a very integral part of the team, providing all-encompassing cancer care to our patients. We've asked Lauren to talk to you about genetics counseling, and the title of her talk today is All in the Family, How Genetics Plays a Role in Cancer Risk Management. And so Lauren's going to speak a bit, and then we'll have a bit of a dialogue and some questions and answers. So thank you, Lauren, for being here this evening.
Thank you, Dr. Deming. I'm going to go ahead and share my screen here. All right, so as Dr. Deming said, my name's Lauren. I'm a licensed genetic counselor at MercyOne Cancer Center, and I work with patients at the Cancer Center as well as others who are concerned about a family history of cancer. So tonight, what I want to talk about is why that family history is important in terms of our cancer risk, and then take it one step further to help us differentiate what types of information to pay attention to. So in this talk, I'll be discussing what makes hereditary cancer risk different from familial, and what do each of these things mean for an individual. We'll then talk about my role and what someone could expect when meeting with a genetic counselor. Often when people see a genetic counselor, they decide to have genetic testing for hereditary cancer risk. And so we'll talk in detail about what that means. And once someone has test results, what does that mean? Let's start with some vocabulary. And to do this, I'm going to use an analogy that we see more often. Our bodies are made up of cells. These cells have a ton of information and can be thought of like a recipe book. No two people have the exact same recipe book, but we all have a lot of the basic things that are the same. Every cell in our body contains the same information, which is organized into chromosomes. These chromosomes can be thought of like the different tabs or sections of a recipe book. The specific information that a chromosome is made up of is our DNA. DNA is a very long string of code made up of 4 letters. A segment of this DNA is called a gene, and a gene is like a recipe. Many of them are recipes for proteins, which have specific jobs in our bodies. So, similar to a recipe, changes to the gene's code can get you an unexpected result. Some changes, like changing from butter to margarine, will get you a different result, but one that still works. Some changes, however, like changing from 30 minutes in the oven to 60, will get you a totally different result that doesn't have the same effect. So some changes in our genes are responsible for what just makes us all different from each other, and some changes can have major impacts on our health. Changes in genes that are responsible for protecting our bodies against cancer mean that the overall likelihood of developing one or more cancers is higher for some people than for others. Cancer is something that affects many people and many families, but that doesn't always mean the same thing. We know that there are many factors that contribute to why cancer develops, and in fact, 80% of all cancers are what are called sporadic. They just happen over time as we age and are exposed to more things over the course of our lifetime. About 10 to 20% of the time, cancer is what we call familial. This is when we see multiple people in the same family diagnosed with cancer, but we don't exactly know why. We know that there are probably some shared genetic and some shared environmental factors that those people have in common that can come together and bump up the risk for cancer a little bit at a time. And then about 5 to 10% of the time, cancer is what's called hereditary. This is where there's a change in a gene that gets passed down through the family that increases the risk for cancer in those individuals. So why do we care? If we look across the top box here of this picture, on the very left-hand side, we can see different cells in our body. We have 2 copies of every gene in our body, and that's what's shown by those 2 black chromosomes. Over time, a cell can accumulate changes that it can tolerate. So that's what you see in that second part of the picture, where there's 1 white chromosome in the middle of that cell. As time goes on, it's possible for both copies of the gene to acquire a mutation. This is when cancer develops. The cell with the mutation can grow uncontrolled and be different from our other cells. Now looking at the bottom photo, someone who has a hereditary cancer syndrome is born with 1 mutated copy of the gene in all of their cells. So you can see that this person has 1 white chromosome in every cell. So it takes less time and there are more chances for a second mutation to be acquired. This is why individuals with a mutation have an increased risk to develop 1 or more cancers. So who is supposed to know or recognize all of this about a family history? How do we find out the information from the questions that we have? That's what genetic counseling is for. A genetic counselor has a master's level education in genetics and training and counseling skills to provide and empower you with the information and facilitate your decision-making process. Our appointment is a collaboration because every family is different. So you will provide your personal and family history and then your motivations for testing. And also, I welcome all of the questions that you have because it's really important to ask those questions. And then I'll provide our evidence-based risk information, new research information, and review what information you might expect to find out from a genetic test. And then we'll work out a plan for testing, getting your results, and acting upon them and sharing them with other family members. When thinking about cancer and our family history, there are certain aspects which might lead you or your doctor to consider talking with a genetic counselor to gather more information. These cancer types have known genetic associations. On the left side here, when we see family histories where there are multiple of 1 cancer type, such as breast, colorectal, uterine, gastric, prostate, or neuroendocrine, it could be a feature of an underlying hereditary risk factor. Ovarian cancer, pancreatic cancer, and medullary thyroid cancer are 3 cancer types that are relatively less common and more likely than others to be genetic. When there is a family or personal history of any of these 3 cancer types, genetic counseling and genetic testing are often recommended. And then the last block here shows that some cancer types, when seen together in a family history, can indicate a pattern that is suspicious for a hereditary cancer syndrome. Some examples are breast and prostate cancers, colorectal and uterine cancers, gastric cancer and a specific type of breast cancer called lobular breast cancer, or thyroid, breast, and uterine cancers. Other factors are important to consider beyond what types of cancer we see. First, how many generations of the family are affected? It's more concerning for a hereditary risk factor if we see cancer in multiple generations, where it looks almost like cancer is being passed down. Second, how old were individuals when they were diagnosed? As I mentioned earlier, cancer risk increases as we age, and seeing family members diagnosed at a particularly young age for that cancer type is more commonly seen when there's a genetic cause than when there's not. Additionally, childhood onset of cancer can be particularly concerning, and we want to pay close attention to those in addition to the adult onset cancers. So you think you might be interested in genetic testing. What should you expect during your genetic counseling appointment? During the appointment, we'll review your personal history and review at least 3 generations of a cancer-focused family health history, which can include ages, cancer diagnoses, and ages that individuals passed away. This could include your children, siblings, parents, aunts, uncles, cousins, and grandparents. And then we'll discuss the features of hereditary cancer syndromes, in particular any that we may see in your family. Next, I will talk about what genetic testing is and how it works and what it looks for, and therefore what types of cancer risk information we could find out. From there, we'll explore these implications and what they might mean for you and for your family, and to determine whether or not you would like to pursue testing. Lastly, we'll review the possible results and what they mean for 1, your cancer treatment options, 2, your future cancer risks, and 3, your family's cancer risks. I've already talked about these first bullet points. So to go from there, let's talk about how genetic testing works. Every cell in our body contains our DNA, so we have several options for what kind of sample to use. Most commonly, patients provide blood or saliva. The lab uses the sample to read through that sequence of the DNA recipe, looking for any spelling changes that are considered mutations. There are then 3 possible results. A positive result means that a mutation was identified and that that person is at increased risk for certain types of cancer. A negative result means that no spelling changes were found and that the person does not have an inherited risk for cancer. And then a variant of uncertain significance means that a spelling change was found that we don't have as much evidence about yet to know if that's a harmful mutation or a normal change that makes you and I different from each other. Most of the time, these are normal changes, but the lab reports them as uncertain until they can further clarify. We look at more than one gene at a time, and this is why family history is so important. We can expand the list or panel of genes to make sure that we look at those related to the cancers we see in a person's family. These genes on the panel fall into 3 categories, and they mean different things for a person's risk and risk management. So again, starting at the left, the first category are considered high-risk genes, where the risk of developing a certain type of cancer is greater than 50% in a person's lifetime. For example, the average woman's risk of developing breast cancer is about 12 to 13%, whereas there are genes that increase breast cancer risk up to 80%. Men and women have about a 5 to 6% chance of developing colorectal cancer in their lifetime. However, there are genes that can increase this risk up to 85%. These are genes or genetic conditions that many people have heard of before, including the BRCA or BRCA1 and BRCA2 genes and Lynch syndrome. There are often multiple types of cancer risks involved, and because we know that these risks have a marked increase over the general population, there is something we can do about it. We have guidelines established for cancer screening and prevention for individuals who have mutations in these genes. This may include increases or difference in yearly cancer screening or preventive surgeries. The second category of genes are what we consider moderate risk genes. We know that these genes increase someone's risk for certain cancers over the general population, but not quite 50%. We do have guidelines for screening and management established, but the recommendations might not be as aggressive as they are for higher risk mutation carriers. And then a third category of genes are called newer genes. These genes are more recently understood to be associated with an increased risk for cancer, but we do not have as much evidence about how they increase cancer risk. In this case, screening and management are often guided by personal and family history after a conversation with the patient and their doctors. The results can take 2 to 3 weeks to be reported, so when I call my patients, it's pretty normal that they need a refresher on the specifics of what we do with the information. If the results are negative, that means that no mutations were identified. It's still important to consider personal and family history in terms of that person's cancer risk, but based on current technology, it's reassuring that this person does not have a hereditary cancer risk factor. If the result is positive, there was a mutation identified. Mutations can be found in more than one gene. Each mutation tells us something about a person's risk for certain types of cancer and what kinds of screening or management options should be made available to them. This result also indicates that other family members have a chance of having the same mutation. So there are some next steps we can take for the patient and their family members, and we'll talk about those next. There are 2 categories of measures that can be taken once someone has a positive genetic test result. Managing someone's risk is done with increased screening for the cancers they are at risk of developing, and reducing someone's risk is done by surgical intervention or, in some cases, medication. Next, I want to go into some detail about what these next steps might be, because this is often the biggest question that I get. Usually very early on in a session, patients point out that they understand how this information could be important for their children, but not often how it would help them. So I'm going to show some examples of the increased screening or preventive options that are available to people once they learn that they have these increased cancer risks. For breast cancer, what this could look like is for increased screening, women can start their annual mammograms at a younger age. In addition to that yearly mammogram, those women could also be eligible for a yearly breast MRI and up to 2 clinical breast exams every year. So that's some kind of breast cancer screening 4 times a year, once every 3 months, with the idea that if a breast cancer ever were to develop, it would be caught at an earlier stage. For some women, this is a really reassuring option because they get that increased cancer screening. For some women, this can still create anxiety because it's not actually reducing the risk of developing breast cancer. There are other methods that I mentioned, like our risk reducing options. A medication such as tamoxifen may reduce the risk of breast cancer by as much as 50% if taken for 5 years. And so this is an option for some women. The option of a bilateral mastectomy or surgery to reduce or to remove most of the breast tissue can reduce the risk of ever developing a breast cancer by up to 90%. For colorectal cancer, there are 2 different kinds of genetic syndromes. One is called polyposis syndromes, where individuals are at increased risk to develop multiple colon polyps over the course of their lifetime. For some polyposis genes, the recommendation can be for people to start their colonoscopies every year as early as age 10 to 15. And there are other kinds of genes that increase risk for non-polyposis conditions, where it's just higher likelihood of developing colon and other types of cancer. And so for those individuals, colonoscopies could start as early as age 20 to 25, or 5 years younger than that earliest cancer diagnosis in the family, and also still recommend colonoscopies more frequently. For patients who've had a colorectal cancer, the extent of a surgery might also be guided by a positive genetic test result. For endometrial or uterine cancer, some of the increased screening that's offered is really about patient education about what the symptoms might look like, as well as an endometrial biopsy to look at some cells from the uterus every 1 to 2 years. Ultrasounds are also effective for women who have gone through menopause. And some women pursue a hysterectomy after they've finished having their children. For gastric cancer, one thing that's offered is screening every 6 to 12 months. And because the type of cancer that is increased with a genetic condition is called diffuse gastric cancer, where it can appear in multiple spots throughout the stomach, a random gastric biopsy is recommended, as well as an upper GI endoscopy, so imaging done down through the stomach. In some cases, the mutation in the gene comes with a recommendation for a preventive total gastrectomy or removal of the stomach. There are some types of cancer where a surgery is not recommended for prevention. One of those is kidney cancer. An ultrasound every 1 to 2 years of the kidney starting as early as age 40 is something that could be recommended if a genetic test indicated that someone had an increased risk. And ovarian cancer, on the flip side, is a cancer where we don't have as great a screening measures as we do for some other types like breast cancer. We know that women who've taken oral birth control pills for at least 5 years have about a 60% reduction in their risk for ovarian cancer. And that some women who still have their ovaries benefit from having a transvaginal ultrasound, a pelvic exam, and a blood test called a CA-125 twice a year. Truly, the recommendation for women who have a genetic risk factor for ovarian cancer is to have their ovaries removed. That's recommended as early as age 35 to 40 and can reduce someone's risk of ovarian cancer by up to 96%. Pancreatic cancer is a cancer that is very difficult to do screening for. One thing that can be done is either an MRI or an ultrasound of the pancreas, and these protocols are guided by a research study. It's felt that it's best to do pancreatic cancer screening as part of a research study, and this is something that we get concerned about when we see a patient that has both a family history and a genetic mutation that increases risk for pancreatic cancer. So still a couple of risk factors. And this is because we're still developing those best practices in screening for pancreatic cancer. Prostate cancer is another one where surgery is not recommended, but prostate cancer screening can begin for men younger than in the general population. And then for thyroid cancer, there are again multiple types of thyroid cancer risk that can be involved depending on what gene there's a mutation in. For some genes, the recommendation can be for a yearly thyroid ultrasound, and the age that it's recommended to start can vary depending on the gene as well. There is one specific gene, the gene called RET or RET, that causes a condition called multiple endocrine neoplasia type 2. With this mutation, the risk for thyroid cancer for a specific type, medullary, is close to 100%. And so there are different screening recommendations for individuals with this condition, such as a serum calcitonin screening and then neck ultrasounds and CTs to look at the thyroid. These can be done every year. There are some specific mutations in the RET gene that indicate that the person should have their thyroid removed as early as possible, even within the first year of life. So that's some of the information that we talk about in specifics to how that can benefit one person and what they might do with that information. Often I find that once we've discussed that information, patients are feeling a lot better about what they might do and how it might benefit them, rather than just creating more anxiety about cancer risk. So the other piece of news is sharing with the family. And why is this important? Cancer genes have what's called an autosomal dominant inheritance pattern. So if we look at the left side over here, we see that there's an affected father. So meaning that one of his chromosomes has the blue color because that has a gene with a mutation in it. His other gene is purple because that doesn't have a mutation. So for someone who has a mutation, we pass on one of our two copies of our genes to our children. And it's random, it's a flip of a coin every time. So every child has a 50% chance of inheriting a mutation and a 50% chance not to. So as you can see here, that affects both men and women. So both sons and daughters would be at risk to inherit the mutation, whether it came from their mom or from their dad. The same is shown on the other side of the picture, just as if mom were the one that had the mutation. And that's just to show that, again, both men and women can inherit this from their mom or their dad. For some conditions, if both mom and dad are carriers or have one copy of the gene with a mutation, there can be additional risks to children. So again here, if we see that dad has one blue gene where it has the mutation and one orange gene where it doesn't, and mom is the same way, they could both have increased cancer risks, and then that means different things for their children. So starting at the left here, there is a 50% chance that the mutation gets passed on from each parent. So there is a 1 in 4 chance, or 25% chance, that a child inherits both of those copies. There are some genes where when a child inherits 2 mutations, one from each parent, they can have a more severe condition that could include birth defects or childhood onset cancers like leukemia. There's also a 50% chance that other children could have one mutation, getting it from either mom or dad, just like we saw on the last slide. And then there's still a 25% chance that the child would inherit neither mutation, as shown with the girl on the left that has both orange copies. So some of the conditions that I'm describing where there's these childhood onset of cancers are Fanconi anemia and constitutional mismatch repair deficiency. I'm not going to go into detail about those, but this is something else that I talk about with my patients who are still planning to have more children or have young children. MUTYH-associated polyposis is another one. This does not necessarily have childhood onset, but the gene MUTYH is one of those genes that causes increased colon polyps over the lifetime. And someone has to have a mutation in both copies in order to have that increased risk. So that's another one that we can see in both children and adults. So this is why talking about our genetic test results can become important. It can become very timely for people. I often find that there are a lot of considerations on why someone would ultimately decide to have genetic testing. And because this is also something that has to work for someone's life. This isn't just a one-off. This affects multiple family members in multiple aspects of life. Some of the things that I think that people find difficult to kind of work through initially are that they can have changes in their perceptions of their health. So sometimes we work through with a patient who might be healthy, has never had a cancer diagnosis, does not have very many medical problems. And if they find that they have a positive genetic test, they might have a different perception on their health overall. Having that cancer risk might be something that makes them feel like they're not as healthy as they thought they were. And that can be difficult. Some patients also find the timing to be not great for them. So there could still be grief from a lost family member if we're talking about a lot of different cancer risks. And some patients find that thinking about ways to screen makes them feel guilty or like that somebody else could have avoided this. So we work on those feelings as well. We also find that sometimes patients have anxiety about how this could impact other family members, especially their children. And so we work on that as well. And again, in all of these, talking about how there is, even though this is our genetic information that we inherit and that we pass on to the next generation, there's nothing that anyone did or didn't do that could have caused or prevented this from occurring. This is just something that we now know information about. There can also be a hard time dealing with the differences between test results for family members. So if I have multiple siblings that I'm dealing with or that I'm meeting with and they have different test results, that can be really hard, both for the patient who has a positive test result in feeling some hard feelings towards their sibling who doesn't, but also some survivor's guilt for the patient who doesn't have the mutation. Patients are also often concerned about insurance and insurance discrimination. Genetic testing is often very affordable. Historically, it used to cost thousands of dollars. One of my main jobs is to make sure that we are looking into as possible and to find an affordable option. I always have a couple of options in my pocket, so the most that a patient should ever pay is close to the $200 to $300 range, depending on what their deductibles and what their own insurance costs pay for. And then with discrimination, we also talk about 2 laws that are in place that protect this information for most people, and that there are other laws that protect federal employees. The first one is HIPAA, so that's the privacy law that protects all of our health information. That also applies to genetic testing, and so this information is private. The genetic testing labs are not doing anything with the samples that we're not asking them to do, and they are HIPAA certified as well. They do this for health reasons, they do this for clinical reasons. The second law is called GINA, G-I-N-A, or the Genetic Information Non-Discrimination Act. That law was put in place in 2008, and it prevents health insurers and employers from using this information to raise your rate or drop you. That law does have limitations. It doesn't apply to new policies if you were to take them out for long-term care or for life insurance. And so often patients consider that maybe they want to review their life insurance policy before they have genetic testing to see if they think that it's everything that they want. And sometimes we can find unexpected results. So sometimes we'll have a patient that comes in with a family history of breast cancer, and we might find out about a family history of colon cancer. So sometimes the thing that we expected to find, or the thing that we were concerned about initially, is not the thing that we ended up finding. And so kind of dealing with that shift in expectations or what we do with that information can be difficult. But in all of that, what we work through and the goal of where we get to is that we can empower these people and these patients to feel like they're doing something good for themselves, because they are. And they are giving information to themselves and to their families so that they can be proactive about screening and about taking their health back into their own hands. The insurance coverage for screening services, I found that patients often have better luck getting some more coverage for those screening services. Sometimes if they do have a genetic test result that says that it's medically necessary, so that can also be reassuring for some people. And then there are tons and tons of resources, both locally and nationally, about the supportive community for people who find out that they have a mutation in a cancer-causing gene or a cancer risk gene. That helps people feel like there's somebody else that's going through what they're going through. It's something that you can't see, but it's something that can be risky, but also there's somebody else, and that can be really comforting. So there are Facebook group kinds of things. There are many other kinds of support groups and advocacy groups, specifically for people who've gone through genetic testing, and being able to put my patients in touch with those support groups as well as research opportunities often benefits them psychologically. It makes them feel more at peace with their decision. It makes them feel more like they are taking this into their own hands and they are regaining some control and writing their own narrative. And so again, these are some of the most rewarding parts of my job, is when I can find that someone really benefits from this information and that they've found something good in the ugly and in the hard part. So that's often what we work the most on, is the things on this slide. So with that, I hope that you learned something today about how genetic testing could benefit you in terms of the immediate sense of how can this tell me about my cancer risks, and then what would I do about it. I am very grateful to have been able to talk with you today. So thank you to all of you for tuning in, and I am happy to take any questions that you have.
Great. Thank you, Lauren. Lauren, can I have you stop sharing the screen? There we go. So we're just going to have a little bit of a conversation here. As you know, genetics counseling has become such an important part of cancer treatment. And I can think of times that you and I have been in breast cancer conference together, or colorectal cancer conference together, where we actually pause on deciding what the treatment's going to be for a particular patient until we get the genetic testing. And as you pointed out, knowing whether or not someone has a gene that might predispose them to cancer might influence how we treat the cancer that they have. Maybe give an example from one of the cases that we had in breast cancer, how a woman presents with breast cancer, has a strong family history. Her mother, 2 aunts, and her sister all had cancer. And before we even decide how we're going to treat this patient's cancer, how would knowing the genetic predisposition to cancer influence the way we might treat this patient?
Sure. So I think you just set the scene very well. So sometimes what happens when we're reviewing a patient's family and personal history, there might not be a lot of other risk factors. We might see a woman who is in her mid-60s, so over the age of 45 that I was talking about. But all of a sudden we start to see that there are 3 or 4 sisters that have all developed a breast cancer at some point. There is even a first cousin that's related to them through their mom's brother that also developed breast cancer, maybe at a young age. And so part of my job is to make sure that I'm kind of drawing out that pattern and saying, there's something here, that there are these multiple women in this family with breast cancer. And so I refer to national guidelines to see, is there something about this family that suggests that they should have genetic testing? If so, then what the doctors do is they go back to that patient and they let them know that a conversation with me could give them other options or more things to consider when talking about their cancer treatment. And so then that's part of what we do in our discussion, is we work to get those results back quickly so that they could decide, if it's negative, maybe I am comfortable with having just this breast cancer removed. And sometimes they might say, if there is a higher risk over other women for me to have another breast cancer, I might decide to have that bilateral mastectomy. And now there might be better chance that insurance would cover it. And so sometimes when a patient is really on the fence and there are some other risk factors, this can be one of those pieces of the puzzle that helps them put together that information and make the decision that's going to work best for them over the rest of their life.
Yeah, that's a great example. And so it really comes down to, in the case that we set up, that a patient with no genetic mutations that we know of may feel very comfortable just having a lumpectomy, breast conservation. But if a patient were found to have genetic mutations that put her at high risk, she may decide to have both breasts removed to reduce the chances of having a future breast cancer.
Exactly.
And then there's also the knowledge of what your genetics are if you're a parent, that can help you feel good or more worried about what your children might have inherited from you. Let's go and talk a little bit about colon cancer. You talked about Lynch syndrome and some other colorectal cancer risk factors. Lauren is an important part of our colorectal cancer tumor board. And let's set up an example where genetic testing may influence the treatment that we do for a person with colon cancer. So let's say we have a young person age 42 that presented with a little bit of blood in the stools, had a colonoscopy, was found to have a tumor in the descending colon. The biopsy showed it was adenocarcinoma. And in the process of taking the history from the patient, we learned that the grandfather had had colon cancer, the father had had colon cancer, and 3 uncles had had colon cancer. What information would, what does that, um, what do you think of when you hear a family history like that in a young person? And how might colorectal genetic testing influence how we treat this patient?
Yeah, absolutely. So, in thinking first about the patient's age alone, anyone diagnosed with a colon cancer under the age of 50 should automatically have genetic testing made available to them. And that's, again, because of that surgical decision making. Other features that we see for this patient are, in particular, we see 3 generations of colon cancer. So the most closely related relative to him, his father, someone diagnosed with the same kind of cancer. Seeing that 3rd generation kind of solidifies that we should be suspicious for a hereditary cancer syndrome. The thing that I'm thinking about, as Dr. Deming mentioned, is Lynch syndrome. Lynch syndrome is caused by a mutation in any of 5 genes, and it increases our risk primarily for colon cancer for both men and women, and for women to have uterine cancer. There are other digestive system cancers involved as well, but those are the primary 2 that we look at. So if this patient came to see me, what we would talk about is how a mutation in any of those 5 genes could influence the doctor's decision about how much or how extensive of a colon surgery to perform. Some of those genes increase the risk for colorectal cancer up to 85% in a person's lifetime. When that's the case, there is a recommendation for more of the colon and even the rectum to be removed to prevent more colon cancer from appearing. Some of those genes don't increase that risk as much. So that's another part of our conversation, is that ultimately the doctor will take this information into account with a personal and family history to help make the decision that's going to, again, work best for the patient. But this can be something that comes with a recommendation that really clarifies that.
Yes. And did you ever meet Dr. Lynch?
I didn't get a chance to meet Dr. Lynch.
So he was at Creighton, and he was one of my professors at Creighton. So I graduated from Creighton Medical School in 1980, and Dr. Lynch just died just a couple of years ago. A long career, and he really was a bit of a detective, because he didn't have a strong background in basic science, and he wasn't an epidemiologist. He just recognized that there were lots of family members having colon cancer and that he was taking care of. And over the course of his career, he basically just started collecting the data on the family histories of patients with colon cancer, finding all of the different family members. And it wasn't until well after he had basically collected all the family pedigrees that scientists started looking specifically for the genetic abnormality. And maybe comment a little bit on how our knowledge of genetic mutations is evolving. Obviously, in Dr. Lynch's case, he recognized family history and family connection long before we had the technology to actually detect the mutation. What do you see happening nowadays, and how often do we need to do repeat genetic testing because there might have been a new gene discovered since the last time a patient had genetic testing?
Absolutely. So in a very similar way, in finding out a bunch of family histories that looked very similar, and how Lynch syndrome came to be developed and established as a true thing, and then finding the genetic causes, this also why we know, and why historically when people think about cancer and genetics, they probably first think of breast cancer. The first things that people started to notice were younger women, women in their 30s and 40s being diagnosed with breast cancer. And then that multiple generation family tree with multiple women, or women having breast cancer in both of their breasts, or some of those higher risk kinds of features in breast cancers. And so that's true. For a long time, we knew about a handful of genes related to one type of cancer or another. We have come leaps and bounds since then. Cancer genetics is kind of the baby of genetics, where it's a very new field. And so what we know now is that anyone who's had genetic testing prior to around 2010 or shortly thereafter probably has not had what we consider up-to-date current technology genetic testing that's completely extensive. Prior to that, it probably looked at one or two genes. Maybe someone's even, for women with breast cancer, maybe they've even had genetic testing twice on the same two genes, the BRCA1 and 2 genes, as our technology became more extensive of those two genes. We can now test very commonly. I order a panel for 47 genes. So we have grown leaps and bounds, and we know about many different types of cancer risks involved. We also know that those genes that we've known about for a long time increase risk for more cancers than we originally thought. In the same vein, we've also found out that some of the genes that we initially thought had some increased cancer risks don't. They kind of have evened out over the course of time and study to be taken off of those genetic testing panels, because that doesn't actually give the patient any new information. So we've come a long way from, in the early 2000s and the late 90s, testing for one or two genes related to breast cancer, to now testing regularly up to 47. There are some panels 77 to 89 genes, depending on what types of cancers we see in the family. So we learn a lot all the time.
I have a question for you about how you try to communicate the magnitude of risk. So, you had one slide that talked about up to 50% chance of risk. That's a pretty easy concept for people to understand. When you get down into the order of, a 3% risk or a 4% risk, and I tend to think that patients, in talking to them, tend to think of those as huge risks and find it hard to put it in perspective. I often use examples, and I'm interested in examples you use, like being struck by lightning. What's the risk of, getting in an automobile accident? And you think of when you first start driving, and the idea of driving 80 miles an hour on a freeway is like, you think you're going to die. And over time, many things that we do that have risks associated with them, we just sort of forget about the risk because it just becomes second nature. What are some ways that you use of communicating to patients and their families of the magnitude of a risk and how to put it in perspective?
So one thing that I do is I start by grounding us with the general population risk. So we might say, in the general population, a man's risk to develop breast cancer is 0.1%. That's 1 in 1,000. For a man with a BRCA mutation, that risk can be up to 9%. So that's almost tenfold. So even in that sentence that I've just said, I've shown a number, and I've illustrated a number in a couple of different ways, where I went from 0.1%, which might sound very small, to 1 in 1,000. And that might seem different, but that's really the same number. So you kind of have two ways to look at it. We also talk about that 9% still being a 91% chance that that man never develops breast cancer, even though he has the highest genetic risk we know about. 91% chance is still an A. That's still pretty good. So we talk about it like that too. Sometimes I use grade levels to talk about that kind of a thing. Also, in terms of that 50% chance, sometimes patients start to tell me that they're convinced because they're more like their mom's family, or they're more like their dad's family, or they're more like their one sister than another. They already have in their head which way it's going to be. And I always remind them that it's a flip of a coin. We can talk ourselves into many different things, but it is truly a flip of a coin. We do not know which of those two genes we inherited from our parent. And we have over 20,000 genes in our body. So the way that those 20,000 genes combine from both mom and dad can make us look or behave or be more similar to one sibling versus another. And so when it's a flip of a coin and we're thinking about one of those 20,000 genes and you have 2 copies of both of those genes, we got to kind of zoom out and zoom in on our perspective a little bit in different ways. So those are some of the things that I like to do, is also flipping that risk, especially to talk about, 1, how random it truly is, and then 2, even if we're talking about increased risk, what is the other side of that? There's still always another side.
And Lauren, where do you think we're going with genetics? What does the future hold? What would you predict 10 years from now, knowing how fast genetic science is evolving? What would you see happening? And maybe also, to the extent you feel comfortable, talk about the genetics of the cancer cell and how knowing about the genetics of your germline and the genetics of the cancer cell are 2 different things.
That's a great point. So one thing that is becoming more and more evident all the time, and I get many, many phone calls from many people trying to tell me about their product, but that's their job and that's a good thing for them to do. Many cancer treatment drugs now can be specifically targeted to a mutation that someone has in the germline, and the germline being the thing that we can pass on, the thing that we inherited, versus just a couple cells of our body. So now what I see more in the future is, as we understand better how different genes do different things in our cells and how changing them and how a mutation affects that and makes it a cancer, we can develop more drugs that are more specifically targeted to shutting that thing down, or maybe even correcting it so that the cancer doesn't have a chance to grow anymore. So I really feel like that precision medicine kind of thing is moving into more of our chemotherapy and is giving us better chances at treatment and better chances at cure.
Excellent. Chris, do you have any questions, or are there any questions from our audience?
If anybody has a question, you can sure use the Q&A or the chat function at the bottom of your screen. A couple of questions I had. One, do you ever see this being sort of the person off the street coming to your office and saying, I'd like to be genetically tested? I mean, what we've talked about is patients who have already been diagnosed, or maybe they've been identified as a possible risk, but I wonder what your thoughts are about that.
Yeah, so in some respects, it does happen. Some patients are very concerned. Some patients have one person in their family history that's ever had a breast cancer, and that's very concerning to them. So they want to know. And so by my definitions, that person would, by all the definitions that I use, that person would not qualify for genetic testing based on our professional criteria. However, we do still have many options. The labs that I work with often have a patient pay price where they don't have to run it through insurance, and so they have like a flat fee that patients can pay. So this can be very accessible information. We spend a lot more time in those sessions talking about what are the implications, what information do you want from this, how is this going to help you? And not because I'm trying to detract this person, but really helping them through this decision-making process of, this can be more than you think it is. Let's talk about this. I also find in another way that patients have either done or learned about 23andMe or Ancestry DNA, and those kinds of kits that are available at Target or on Amazon. Those genetic tests work in a very similar way, but the technology is different in that they are not FDA approved to do anything that is clinically relevant. So the genes that they look at or the markers that they look at are things that do not have clinical relevance. So they look at different genes. There's a little bit of overlap, and they have very little FDA clearance compared to what we do at a cancer center in terms of finding that information that can be relevant to your healthcare.
That's good. Good to know. Okay, there is a question from the audience. This person was tested back in 2006 and was found to have, and I'll say this, HNPCC or Lynch syndrome. Should I be retested?
Great question. If you've already had a positive result, that is going to stay. once we know that someone has a positive test result, your genes don't change. So that's something that's always going to be there. But when we're talking about when people previously had negative results, this is a good way for me to clarify. People who previously had negative results may be able to benefit now from more in-depth testing. Once you've already had a positive, we would expect to still find that again. So your test is still up to date.
How long does a patient typically wait for their results? I think that could be a source of great anxiety
Yeah,
as a cancer patient
great,
myself at times.
That's a great expectation that we set. So in some of the situations like Dr. Deming and I were discussing where there are instances when we can work to get the results back in less than 2 weeks so that that patient has them for their surgical decision-making process. But the standard turnaround time is between 2 and 3 weeks. And that's days, not business days. So that's sometimes a little bit clearer for people. But they know that they will expect a call from me within a month.
Well, great. Well, Lauren, really appreciate your sharing your knowledge with everyone. As we've said several times tonight, it's become a very important part of cancer care, and it's going to become even more important, and we're very fortunate to have you on the team. If anyone in the audience wanted to chat with you, to talk with you about genetic counseling or genetic testing, what would be the best way for them to reach you?
Yeah, so if you were thinking about talking with your doctor, or if you think that what I've described sounds like this could be something that your family would benefit from, the best thing to do is talk with your primary care doctor about getting a referral to the genetic counselor at the cancer center. If you have questions about the profession or something else like that, or you just had one quick question from this talk, my email address is lwinter, like the season, WINTER, @mercydemoines.org. I'll get back to you within a few days, but I'm happy to answer any questions that you have.
Great. Thank you so much, Lauren, and thank you everyone for attending. We'll see you again next week.
Yeah, remember that these are recorded and they'll be on our YouTube page for Above and Beyond Cancer, and also on the website, the MercyOne website for the Cancer Center also has these recordings. So, Lauren, thanks very much.